Assalamu alaikum wa rahmatullahi wa barakatuh. Very good evening. This is Health Matters. I'm Khawa Solomon. Joining me today on the panel is Dr. Yaqub, and we are trying to understand the effects of strokes. What is a stroke? What's happening during a stroke? What do you need to do after the stroke? We have specialists in studio with us, Professor Firoza, as well as Dr. Pradeep, our neurologist. Professor Firoza is emergency and family physician heading the emergency unit at Charlotte Motleke Johannesburg Academic Hospital, as well as academic head emergency afterwards. Assalamu alaikum, and very good evening, guys.
Good evening to you. Thank you.
Thank you so much for joining us. This, of course, is an important topic. Strokes, Dr. Yaqub, is not often recognized as a stroke, and there are lots of myths and sort of ideas around what's happening, what needs to be done, what do you need to know. So let's get this rolling.
Yeah, I think I'd like to start normally just to discuss. People talk about the term stroke, but it's been thrown around all the time. So and so had a stroke, this one had a stroke. But perhaps from your professional definition, what is a stroke, Firoza?
So essentially, stroke is equivalent of a heart attack in the brain. It's when part of the brain gets blood and oxygen cut off, either as a result of a bleed in the brain or as a result of a clot that's blocking supply to that area of the brain. And the longer the tissue is without oxygen and blood supply, that area beyond the blockage or the bleed then dies off. And that's essentially what a stroke is.
So Pradeep, how common is a stroke in the general population and then again in South Africa?
So we don't have proper statistics in South Africa. So that's one of our biggest problems. We really don't have what Firoza sees and this public sector sees and what we see in private sector. So giving you exact figures would be a bit incorrect, but if we look at the global burden of healthcare, if we look at heart disease as number one, then stroke and stroke-related complications are number three. So, one is heart disease, second is cancer, and then third is stroke. So, it's high there amongst them in terms of mortality and morbidity.
So I think the big question as well, Dr. Yaqub, is also how do you identify the stroke?
Yes.
Dr. Firoza, Professor Firoza.
So it's sudden onset of symptoms.
Yeah.
That's the big thing. So anything that's gradual is unlikely to be a stroke.
Yeah.
If it's sudden onset, we use an acronym called FAST, which stands for facial droop or facial, unable to smile or show your teeth. A is for the arms. So if the patient's or the person's unable to hold their arms up, ask them to hold both arms, and if they can't lift one or one droops down.
Okay.
S is for speech, which is slurred speech or unable to understand or to vocalize. And the T is time, and that's the critical factor, is getting the patient to a healthcare facility in time. And essentially all those symptoms are of sudden onset.
Let's talk about the time, because that's for me on the top of the list there. What is the time period?
Essentially, it depends on the type of stroke. So if you have an ischemic stroke, which is the stroke that happens as a result of the clot, you literally have about between 3 and 4.5 hours to get to a healthcare facility if there's a possibility for it to be treated. Beyond the 4.5 hours, there is some treatment, but it's not available widely and it's not accessible easily in many of our facilities. So the bottom line is you need to get to a healthcare facility, because for every minute that you delay treatment, you're losing 2 million brain cells.
Sure.
So you can understand the critical reason to get to a hospital or to a healthcare facility quickly.
That now immediately makes me want to understand what we should do, Dr. Yaqub.
Yes, obviously, so you've got to recognize the signs immediately, Dr. Raji. But before we just get to that, the other form of stroke is the hemorrhage, right, which Feroza spoke about, the infarction. So is there a difference between the two? That one, the time period 4, what are your chances of getting...
So, just to clarify very
Yeah.
importantly, that's that ischemic strokes, which is basically when you block off an artery with a clot, makes up the majority of strokes. 85% of strokes are going to be ischemic. Small subsector of those are hemorrhagic strokes. The hemorrhagic strokes, there's 2 types. There's not just one type. The first type is when you bleed into the substance of the brain, and that's called an intracerebral hemorrhage. And then you get the second type, which is where the bleeding is around the brain, and those are called subarachnoid hemorrhages. And the type of vessel disorder is slightly different. The intracerebral hemorrhages are killers, just as intra or subarachnoid hemorrhages are killers. They're very, very abrupt in onset. As that blood vessel bursts, there's an intense pressure within that brain compartment, which is basically a fixed compartment. If you think about it, your skull's a solid structure with which is closed, and so it can't dissipate pressure easily. That pressure has to be dissipated, and one of the things that happens is you lose consciousness very quickly. So the person would say, or complain of a pain or a headache, and very soon after start developing either weakness or loss of consciousness at the same time.
Okay.
Some people can go on to have a seizure, so it's very dramatic, almost, theatrical in the way it presents. Bang, and the person's on the floor. So the presentation is very abrupt and aggressive, and the patients are very, very ill at the time that they come to hospital. And not only is it an abrupt and aggressive illness, we lose a large number of patients in that particular type of stroke.
Okay.
So the question I would ask, when people have a heart attack, we've been constantly told do some CPR and you can get your patient in time. Firstly, how would a family, if somebody's having a stroke, recognize if they can, and can they do anything? Or just put them in the car or in the ambulance and get to the hospital?
Go.
So the biggest message we want out there is the fast message.
Yeah.
Which Feroza mentioned.
So, in the old days we used to say time is heart, and now we're saying time is brain, right? So as long as people understand that the sooner you recognize that symptom, the faster we want you in hospital. And I just want to give you a quick demonstration, right? So the patient describes that they've got facial droop, and so the face will go down, and you ask them to lift up their arms, and if the arm drifts downwards with a speech deficit, no time to waste. So that's one thing. The other aspect is to put a Disprin into their mouth, even if they are on Disprin. And people have asked, so what happens if it's a hemorrhage? And really the studies have clearly shown that it makes no difference, because the vast majority of patients are going to be ischemic strokes.
Yeah.
So you're not going to harm them. And even if the ones that did have a hemorrhage, the hemorrhage is not going to get that much worse if you put the Disprin. So for them, get them into an ambulance or into a car and drive them to the nearest health facility, wherever it is, because there's treatment now. And for either of the types, there's treatment that could be administered, whether it is intracranial surgery or whether it is medication to break down the clot. There are options in terms of treatment. So we can improve outcomes in these patients. So urgently get the patient across. So that message is that time is brain, and we got to get that patient across as fast as we can.
Professor Feroza, you want to add anything?
No, I agree. I totally agree. It has to be the message that we want to get out there is that, like Pradeep says, it's a brain attack. The same way as you would rush to hospital if you're having chest pain. Any sudden onset of what we call neurological symptoms should be treated with the same urgency and get to the hospital as soon
Not the
as
doctor.
possible. Well, if you're going to a general practitioner or you're going to a clinic first, you're just extending the time interval at which you're going to get to the hospital eventually. And as I said to you, you're losing brain cells every minute.
So hospital is
it's
the best port of
critical
call.
to get it.
Yeah, this is a very serious medical emergency, so you've got to get them to a proper emergency unit facility as fast as possible, wherever you may be. And obviously people that have the greatest difficulty are those that have accessibility to hospitals, those that are living in rural areas, far away. And that's, I suppose, where you see the statistics, higher mortality coming through. And obviously we're very fortunate in the bigger centers, but you have problems with this kind of thing. But some of the things that lead up to stroke, right? The risk factors. We always talk about risk factors in almost everything, but that's the reality of life. So,
okay, so there are some risk factors that you can change, which are called modifiable risk factors. There are some you can do nothing about. So the fact that you're female, that you're older, that you have a family history of some predisposing genetic conditions which would affect your vessels or your cholesterol or those kinds of things, you can't really change. The things you can change: smoking, alcohol, obesity, underlying heart disease that's not being treated, and a very big one in our population that is really not treated with the urgency it deserves is hypertension, and then associated with that is underlying diabetes. So essentially the same lifestyle diseases that you would have for a cardiac patient, it's the same pathophysiology, the same way the disease process evolves is happening in your brain. So it's monitoring your glucose, monitoring your blood pressure, and taking your treatment, making sure that you exercising regularly. If you smoke, you have a 6 times higher risk of having a stroke than someone who doesn't. So there are huge implications for the lifestyle problems.
I just want to quickly come in here with this with regards to the symptoms and what doctors explain about the slurred speech and the conscious or the unconscious. And often, you relate it to, an older person of older age. Does it occur in, and if this does occur to somebody of a younger sort of generation and younger of age, should it also be of concern?
Yeah, absolutely. So strokes don't only affect old people, okay, which is what we've always believed. It can affect people literally from the time they're born, depending on the cause. So often in little babies or in children, it's something genetic, it's something with a vascular abnormality that would or clotting disorder that would predispose them for it. But the majority of the strokes do happen in older patients.
Okay.
Teenage girls particularly, or young women who start an oral contraceptive pill, for example, are at risk. It is a risk factor. It's not extensive, but significantly if there's an underlying clotting.
Just explain that quickly.
So
what's happening?
Essentially what happens is you start an oral contraceptive pill which affects your hormone balance, and that can affect your clotting profile.
Okay.
So it'll predispose you to having a greater risk for clotting in the vessels, and that could cause an ischemic stroke.
Clotting.
So just especially in families where there is an underlying inherited disorder, so there are protein deficiencies and things that could affect it. And be aware of that when you're going to your GP or your gynae, for example, and you're saying you want to go. And a lot of the young girls are taking the pill for acne, for their skin.
Yes.
And just be aware of that. Say to your doctor that I have an underlying disorder, or I have a family history of stroke, or
Absolutely.
I have a family history of clots or a pulmonary embolus or that kind of thing. It makes a difference.
Know your family history and medical
Absolutely.
history.
Yeah.
We're going to take a quick break. Thanks, guys. And we continue the discussion on understanding the effects of stroke. We'll be back just after this. Remember, we're taking your calls as well. Back in a moment. Assalamu alaikum, a very good evening. Welcome back to our live show on Health Matters. That means we can take your calls, so call that number on the screen, and we're talking about understanding the effects of stroke. Dr. Yaqub, Professor Firoza, and Dr. Pradeep in studio with us, neurologist and heading emergency units in her specialist physician cap that she does hold. We're talking about strokes, understanding it, the effects of it, why does it happen, what is happening, what we need to know. So what I took from there was fast. Time. Within literally 3 to 4 hours, the sort of movements that you explained, Dr. Pradeep, about the hand and the slurred shape of the mouth and the Disprin. That for me was understanding that, and because I know of often people say, when I was pregnant at least, they said my sister was prone to thrombosis. I might be, so just take a half a Disprin anyways. So that Disprin for me immediately clicked because of the clots that is happening. So have a Disprin in your house. That's something I don't have in my home. We don't take Disprin. So okay, there we go. And a woman's bag have everything, eh? All right. So Dr. Yacoob, we've still, have we covered everything in what's
we
happening?
haven't.
Yeah.
Look, what I would like to cover, obviously, Dr. Rauji, is the role of headache. There's a strong association between hypertension, obviously high blood pressure, and stroke. But we find patients in primary care, in general care, that actually stop their medication for blood pressure. They said, because I'm no longer getting my headache. And they feel that headache is a very big symptom leading to high blood pressure, or a recognition of high blood pressure, which obviously then is a risk factor for stroke. So what's your take on that?
So, I mean, I'm sure you've heard this all. We've heard it every other day.
Yeah.
So the patient comes and says, I know exactly when my blood pressure is high.
Yes.
I get this feeling and I get this headache, and there's never been a scientific study to date that has proven that headache is a feature of your blood pressure. And if it is, then the blood pressure is so high, you should be in an ICU. You shouldn't be talking to me.
Yeah.
We should be putting you in hospital, and we should be admitting you to the ICU. So I think that myth has to be dispelled.
All right.
And there's many patients who insist that they can tell exactly when their blood pressure is high. And the worst part is when they tell you that I only take my medicine when I feel
When I get the headache, yeah.
it's a total myth, and so we shouldn't propagate
Finding out
that.
all their little
Yeah, we shouldn't propagate that. That's a complete myth, and it should be avoided at best. The best way to test it, obviously, is every time you get your sore throat seen to, make sure that somebody checks your blood pressure. We have to have blood pressure screening because it's a basic screen. And if that isn't the case, you can go to your Discams, you can go to your nearest pharmacy,
Pharmacies.
and you can buy a wrist blood pressure device these days from your nearest pharmacy. So there's many ways to check your blood pressure without having to guess it. Thumbsuck with a headache phenomenon.
What
And
is
today
that
there's a lot of
regular?
wearables,
Yes, yes.
that
Oh, it's
measure
so
lots of-
easy.
And they
Things are so
measure,
easy.
so
Yeah.
it's becoming much easier. Sorry to interrupt you there. Yeah.
No, I know. Whenever you go to the doctor, you
Yeah.
visit the doctor, they put this machine
Yeah,
on.
no,
So
that
what
is
is it?
standard.
So what is the regular? What is regular if you're not going to the doctor often? I know people that only go for the once a year check. So
So
what is
the
regular?
international guidelines say bring you as close to 120 over 80. Anything above that is abnormal. This circle has gone on for years, that the numbers went to 140, then down to 130. And if you're diabetic, lower. The bottom line is get you as close to 120 over 80 as we possibly can. However, there's a different set of guidelines for the older patient who have stiffer vessels. And they get different types of blood pressure changes. But that's a medical entity, not anything that
And is this a
everybody-
once a month check?
Well,
Once a week check.
Again, the guidelines. The guidelines say if you're not hypertensive,
Okay.
a minimum of once or twice a year. Okay, but if you have a family history or you have high blood pressure, then obviously it needs to be monitored a lot more frequently. And there's a reason why it's known as a silent killer, because the majority of people walking around, 1 in 3 people in South Africa is hypertensive. And that's a huge risk. So, and I'm 100% sure that 1 in 3 people in South Africa are not on treatment or taking their treatment.
Sure.
So the fact that they're walking around with their high blood pressures and there are underlying changes that happen in their kidneys, in their eyes, in their blood vessels continuously for as long as their blood pressures are high, is a risk that's developing. And then all of a sudden one day you have your stroke or you have your heart attack, and it's because those things have been developing over time and nobody's bothered.
And you're not even sure as well. So just quickly, is there something like a mini stroke? Because I've heard somebody as young as 30 had, a scare, and when we heard the word stroke, we we couldn't believe it.
So that's one of the things that we describe as a little volcanic eruption.
Okay.
So the most important thing to remember is that the stroke is connected to the rest of the body, right? So as much as we'd like to talk about the brain as the primary or the end product of the disaster, usually the clot usually starts off elsewhere. And so usually you get a clot in the heart because of a valvular abnormality or a chamber enlargement or a previous myocardial infarction or previous heart attack. And so the clot forms in the heart. And then like a cannonball, it gets shot up into the brain. And sometimes you get that cannonball going up, but it's a very soft, friable clot, and it breaks up very, very quickly. Boom. And so the person gets a hemiplegia, which is basically a weakness of one side of the body,
Okay.
with the facial droop, with the speech, and within 20 minutes, it dissipates. And they're walking about like nothing happened.
Okay.
That is a volcanic eruption. If this was in the Indonesia or any other part of the Asia Pacific, they tell you to evacuate your village. We want you to evacuate from your house and get to a health facility. So in essence, a TIA is an impending stroke.
Okay.
Don't sit on it.
TIA. Right.
That's the medical term, so it's called transient ischemic attack. But for the
Yes,
viewers,
Susha's
that's your mini stroke.
TIA.
These are the signs. So if you get a sign of a stroke, that's what Dr. Raji is saying, and it suddenly recovers, don't say, right, everything is good
Fine,
and
yeah.
everything's happiness.
Move
That
on.
is like a second
Go check
chance.
it
You're
out.
getting a second bite. Get to your nearest
Yeah.
facility and get it checked as soon as possible, and obviously describe the symptoms as accurately as possible too, so then a proper assessment can be made.
Absolutely. We are taking calls,
Yeah,
Dr.
sure.
Yaqub, and to our panel as well. Please call the number on the screen for any stroke-related questions. This is Health Matters. A very good evening. We will also ask our viewers to please turn down your television set or just the volume of it. We will have a lot of background noise, and unfortunately you will not be able to hear us as well, which is a problem when you can't get your question across. So please turn down your television. This is Health Matters. A very good evening. Assalamu alaikum.
Alaikum salam.
Are we speaking to?
It's Yusuf. Yeah?
Yusuf, Assalamu alaikum, sir. You've got a question to our panel, our medical fraternity. Go ahead.
4 questions, if possible, to take me.
4, okay.
Injuries during your youth period, can that precipitate a stroke at a later stage? And can even such a thing as you having smaller strokes without you being aware of it, and then one day we have a big stroke, and that can cause serious brain injuries. And then has aneurysm got anything to do with strokes? And then the fourth question is, your blood pressure is very high. How do you normally bring it down? Gradually, or what do you actually do? Because I know if you want to do it very quick, it will cause a big problem.
Okay. Shukran, Yusuf, for your call. We appreciate it. All the best. You can listen to your television now and turn up the volume.
Okay, thank
Okay. Wa alaikum
So
salam.
there's
All right, there was 4 questions, eh?
4 very good
Yeah.
questions. So the first one is previous injury, if it predisposes you to stroke.
Right. So the only way that would predispose is if, say, for example, you had an accident and you damaged the lining of one of your blood vessels that supplied your brain. That would predispose you to having a clot that would form in that area, which would then shoot off into your brain. Otherwise, the other obvious thing would be an actual traumatic event, which would cause a bleed in the brain. And then his last question, just in terms of
How aggressively do you bring the
aggressive
blood
you bring
pressure
your-
down? Does it have an impact?
It does. So if your blood pressure is significantly high, you have to bring it down. But there's a whole protocol in terms of reducing it at so much per hour so that you don't suddenly reduce it. Remember, your brain and your organs have been used to functioning at that higher pressure and getting blood and perfusion at that higher pressure. If you suddenly drop it, you're making that tissue almost deprived of oxygen and blood. So you have to reduce it gradually so that there's almost like an accommodation and the tissue then doesn't suffer from.
So it's done under supervision
It
with
must be
your
done.
practitioner, and
Absolutely.
and it's a guided
Particularly
process.
if the blood pressure is very high.
Okay.
And then the mini stroke, not realizing if you're having a mini stroke and then later on in life having one. Is that
There's the
happen?
problem with that mini stroke phenomenon is that as we age, we get small vessel disease where there's little vessels that are busy blocking up. And when we do MRIs, and I think that's where this question is going,
Okay.
MRI shows up a lot of what we would call ischemic white matter disease. And you'll see it in all the reports that there's ischemic white matter disease. And what that implies is that there's small vessels that penetrate the brain
Okay.
from the arteries of the brain. So I just want to qualify this by saying one very important point is that the brain, almost, if you imagine a dodder on your tree, you know, the parasite dodder, which is supposed to wrap around the tree and then send in penetrating suckers into the host tree.
Okay.
The brain's blood vessels are exactly like that. They form a encasing network of blood vessels, and that encasing blood vessel then sends in smaller penetrating blood vessels that penetrate the brain and supply the deeper parts of the brain. So in a lot of older patients, we find that if the patient hasn't had access to healthcare, for example, in our poorer communities, then they get access and we scan them, and their blood pressures haven't been well controlled, you'll see little ischemic deposits in the brain. But that in itself is not an indication, but it can increase your risk of developing a large stroke, because the very same factors that are causing the small vessel disease are the ones that cause the large strokes.
Yes.
So it's your diabetes, your hypertension, your cholesterol, your smoking, lack of exercise, or whatever it is. So the bottom line is, yes, it can do exactly that. Just one more point about the trauma. Trauma in childhood probably doesn't do that, but trauma a week ago can clearly do that. So we often find
Have a
that
checkup,
recently we had a patient who drove a car
Okay.
into a wall because she was being attacked by bees, and then had a cervical spine injury.
Sure.
And with that she had ruptured and torn her vertebral artery. Or sometimes younger people can develop a dissection due to a variety of other things, like sports especially. But generally then the injury is within a short space of time, within a week or two of them developing the stroke.
Okay.
So injuries from the past shouldn't, by definition, cause...
A recent one would.
You
Okay,
had a fourth
we've got
question.
a
You had a fourth one.
Aneurysm.
aneurysm.
yeah.
Okay,
So-
we have got another call online though.
Okay, do a quick one.
Yes.
So an aneurysm is one of the reasons for risk for a bleed.
Okay,
Because the aneurysm is prone to rupture, and that would cause a bleed in the brain.
aneurysm. Okay,
Yeah.
so please have it checked out if you had a recent sort of injury that could be related to stroke. Okay, we've got another call online. We're taking your calls live. Assalamu alaikum. Very good evening. This is Health Matters.
Assalamu alaikum.
Yes, sir. Who am I speaking to?
You're speaking to Shabir.
Shabir, please go ahead with your question.
I recently had a mild stroke. One of my vessels on my neck was closed, and that was caused this. It was a very scary experience. And recently I was in hospital for a kidney stone. They advised me that it's 62% open. I just want to find out how should I go about improving my health and trying to get this sorted, because somebody suggested I should take a colostrum tablet.
Okay.
I'm just confused what's going on.
Okay, no problem. Any questions for your caller? Shabir, Jazakallah for your call. Please listen on your televisions. Set. Okay, sure thing.
So after a stroke, whether it's mild or severe, we would like to know where this origin of the clot was.
Okay.
So it sounds as though there might have been a stenosis in one of the arteries leading to the
It's a
brain.
narrowing, eh?
So if there's a significant stenosis, there are criteria that we would use to have either surgery or putting in a stent. So that's one aspect of treatment. But the other aspect, which is very vital, it's universal, we need to start secondary prophylaxis, which is to prevent him from having another stroke.
Okay.
And that goes across the board. So if you've got diabetes, we want to treat your diabetes. If you've got high blood pressure, we want to get control of that. Cholesterol, same thing. If you're smoking now, so those are the things that we can treat.
Okay.
The things that you can
We need to
assist
do,
us with,
yeah.
most importantly, is getting into an exercise program and getting your weight down, getting your abdominal fat content down, stop smoking, and that's vital. I don't think we must underestimate.
Yeah.
The medical treatment we've got strategies for, but it's also vital that the patient has
Lifestyle, yes.
a very
Needs to
important
change.
role to play in their own management. Yeah.
Absolutely. We
Sorry for that. Yeah.
we need
Just
to
to
quickly pay the bills, and when we come back,
okay.
we'll head right to Dr. Yaqub's question. We're taking your calls. Don't forget, thanks so much to the gentlemen, Yusuf and Jabir, for their calls. We have more on strokes with Health Matters just after this. Assalamu alaikum, very good evening and welcome back. This is Health Matters. I'm Hawa Solomon. With me sharing the platform is Dr. Yaqub, and we're talking about the effects of stroke? How does it happen? What is happening? And thank you so much for the calls. We are taking your calls. We have specialists in studio, Professor Firoza, as well as neurologist Dr. Pradeep out at Mill Park Hospital. I'm still getting used to all the Johannesburg jargon, but it's a pleasure being part of the family here. Dr. Yaqub,
I just wanted to add to the last question that the caller, he spoke about the role of anti-cholesterol medication. What's your view on that? Are you putting people on to long-term? Do they have to have a normal lipogram, normal cholesterol profile? And people sometimes go to these health screening days and it's just the total cholesterol is checked, and sometimes they're told, don't worry, your cholesterol is normal. Meanwhile, there's a bad and a good cholesterol. Just a quick summary.
So the guidelines are again very, very difficult to follow in terms of what we're going to do. But again, individualizing treatment for every patient is important. So if you got a very thickened IMT, which is a medical term for the thickening within the vessel, which we can measure with a Doppler, we can then treat that, and then we can reduce the size of the IMT. If there's a plaque, there's no question. You need to start treatment. So then you're not even going to worry about the lipogram picture.
Yeah.
However, then there's the other patient who has a valvular lesion. He's not going to need a cholesterol-lowering drug, a secondary prophylaxis. So I think vital to the role of the neurologist is to identify where the source of the event happened. And that's vital. So if we have an idea as to what the source is, we will then tailor the medication. Having said that, there's this huge controversy at this moment in time raging around the globe about primary prevention and using just the lipogram as an indication to start or not to start treatment. And I think that debate is one that I think
Still out there.
is out there, and I don't know if there's a jury that is willing to comment on it.
We'll wait and see. We've got another caller online. This is Health Matters. A very good evening. Hello, yes.
Hello, assalamu alaikum.
Wa alaikum salam. Who am I speaking to?
Okay, my name is Abdul Shakur. I'm calling from Zimbabwe.
Yes, Abdul, go ahead with your question.
Okay, my dad fell 3 weeks ago. He fell down, and then we took him for a CT scan, and the brain was clear. Then he fell again last week Sunday, and then on Monday we took him for a CT scan, and the back showed there was a huge cut at the back. And then on Monday, up until today, he's been like unconscious. He's been in hospital, and the doctors are saying that look, there's nothing that they can do about this, and because the clot is too big, he can't talk, and I don't know. What do you think would be the way forward here now?
Okay. Professor or doctor, do you have any questions for Abdul? Jazakallah for your call. All the best to your dad, inshallah. The panel will answer your question.
He's a diabetic. He doesn't have high blood pressure.
Okay.
His temperature is very high at the moment. It's above 37. It's been about 37 over the past week.
Okay.
His sugar's been high. His sugar has been very controlled.
Okay.
And there's something else which is up. I'm just trying to think. His sugar, blood pressure, and his temperature. That's also been high. His blood pressure has been very high today. In fact, today it deteriorated quite a lot.
All right.
So what would you think would be the way forward? When we asked the doctor, should we fly him to South Africa, and the doctor said that, look, there's no way you can fly him down because, nothing's going to happen. In fact, if you had to take him to South Africa, he'd deteriorate more.
Even more, okay.
There's no operation or anything that we can do on him. So we're just praying and making dua that Allah makes it easy for him.
Ameen. Dr. Araji's got a quick question for you, Abdul.
Okay.
Did they tell you that the kind of bleed is a subdural?
Yeah, I think yes, it's a subdural. Subdural, yeah.
Okay, so we can comment on that.
Okay. So please listen on your TV set.
Okay.
Jazakallah for your question as well, sir. All the best. Wa alaikum salam.
So the sad part about this particular patient is that, and this is the sad part about where we are. So he's in Zimbabwe, and I'm sure that they don't have access to a lot of good technology sometimes. But we're fortunate we live in a city with all the technology, so that's a good thing for us. But having said that, I just want to make one very important point about CT scanning. If you have a stroke, I'm not talking about the patient. if you have a stroke and you do a CAT scan,
Okay.
the CAT scan can be negative for up to 12 to 14 hours. And the reason is that the CAT scan is less sensitive than the MRI at picking up strokes. So that's just an aside. What this gentleman has is probably a fall, and with the fall, he's developed a bleed around the brain.
Okay.
And that bleed around the brain is putting pressure on the brain, and that is the reason why he's lost consciousness. And in fact, this patient is the ideal candidate for a surgeon to go in and drain it. And in fact, you can save their lives. And it's a procedure that was done in ancient Roman times and even in the ancient Egyptian time, where they still find patients with their skulls with holes that have been created.
Drill
It's
holes
called
in it.
trephination, that was done for battlefield survivors, just in case they could remove the blood from the person's skull. So in the old days, obviously being hit with a hammer. So this is exactly similar to that. And no, I think the patient should be evacuated to a facility as close as possible that has the potential to drain the blood from around
To
the
that
brain.
procedure. Okay.
So he was asking you, Dr. Raji, will it be safe for him to be flown to South Africa?
Absolutely. If you've got an air ambulance, there's no reason why, because they will intubate the patient and evacuate with
So that's the
the
advice you would
necessary
give to him, right?
expertise,
Yeah.
necessary expertise to get him to a facility, whether it's in Joburg or wherever it is.
Yeah.
There must be a neurosurgical facility
Intervention
to be
now.
able to be
With
able
that,
to-
Dr. Yakub, how do you approach the next doctor to say, listen, I got a second opinion, and this is what I'd like for my father? And often people are afraid to, go above what the doctor has advised. That is in the care of the father now.
Yeah, it's about the politics of medicine, unfortunately, and there it can be quite tricky. At the end of the day, there's a cost factor associated with it, about the fact that there is a patient that's alive and so should be treated. And where there's life, there's hope. So, we must give this patient the benefit. And I want to just make one very important point. Subdural hematomas in the elderly patient, even though they look like they're going to pass on in a few hours, once you've evacuated that clot, they all make this miraculous recovery. And the reason is that it's sitting outside the brain. It's not inside the brain. It's not damaging
And you've
brain
removed the
tissue.
cause.
It's possible.
Yeah.
So
It's
to that
possible,
caller, there is hope, inshallah.
Inshallah.
Dr. Professor,
No, I was
you wanna
just
add
going to
on?
say it's about relieving the pressure, because all his symptoms that he's having, the blood pressure effects and all that is all as a result of the increased pressure within his skull, as a result
Which
of
has
the
to be
bleed
released.
Just to release,
displacing
yeah.
his brain tissue. It's almost squashing his brain downwards.
Okay.
So, as Pradeep says, if they remove the blood, then you've relieved that pressure.
So it's important that we need to ask questions and go into detail with that as well, and
Yeah.
understand what is happening with our loved ones. Hey, Dr. Yakub, now moving
so
on.
moving on, look, you've got two levels of treatment with stroke. There's the immediate phase, and then obviously the rehabilitation and the recovery phase. So what's your immediate treatment that you will institute? Obviously it'll be within an emergency care setting, within a hospital, and then subsequently you will then bring in the other interventionists in terms of what they're going to do for recuperation and recovery.
The most immediate thing is making sure the patient's stable when they arrive. So from an emergency point of view, it's assessing the patient. So if they're having difficulty breathing as a result of the stroke, if their vital signs are in any way abnormal, so whatever we can treat as an emergency, we will start treating. And then the most important thing to have done, apart from a few blood tests and some vital signs, and then maybe an ECG as well, would be to get the patient to a CAT scanner. So as Pradeep was saying, the MRI is a lot more sensitive, but the majority of the hospitals that we work in don't necessarily have an MRI. In the private sector, definitely, there's access to it. So it would be getting a CAT scan, and the reason for getting a CAT scan is to exclude the bleed, because at that point in time, the ischemic stroke doesn't have changes on the CAT scan that you'd obviously be able to see, because those changes haven't evolved yet. So if you have a patient who's got got the neurology with a relatively normal CAT scan, then that patient potentially would be someone that you'd be able to treat acutely to dissolve the clot with a drug that you can give them. Not every ischemic stroke patient will be able to get the drug, because there's a whole list of indications and contraindications that you would have to go through. And obviously you'd have to get consent from the patient or the family if the patient was unable to. And the reason for that is that there is a risk with the administration of this drug that the patient can develop a bleed when we give that medication, which would make the patient then worse. So we have to explain all those things to the patient. If the patient then fulfills the criteria that we can give the drug, we give it. There's a particular regimen that you have to follow in order to administer it. The patient needs to be monitored. And I mean, Shukar, we've had patients that literally within an hour of having received the treatment have gotten up and walked.
Sure.
You know, with complete resolution of their symptoms. The other thing to understand is the sooner you do that after the onset of the symptoms, the better your chances of getting resolution. So obviously if you arrive at the hospital at 4 hours, you literally have half an hour to play with, and by then there's already a core of tissue in the brain that has died.
Damaged.
And then obviously, you know, it's follow up and the rehabilitation that takes place with the stroke patient, which is what happens after you've treated, or in a patient who's not eligible for the treatment, needs to start almost immediately. Often, you know, patients wait, and our biggest problem is that patients arrive a week, 2 weeks, sometimes a month after they've had their stroke.
Sure.
You know, and by then you've already lost functioning and tissue in that time.
Okay.
So the whole idea is that if we can start the rehabilitation with a multidisciplinary team, which would include physios and OTs and speech therapists, the physicians, you know, the neurologists, as a group, then obviously that would mean that the patient has a better chance of surviving or improving post the stroke.
Your comments on that, Dr. Ryan?
So I must say the one thing that happened many years back when I started developing a stroke unit and an interest in stroke was I had one of the patients that recovered very quickly after lysing the mina, and then we could identify the source, which was a valvular lesion. You could hear it on the stethoscope, and getting them out of hospital in 2 days on the right treatment and home, and not having to spend months and months in hospital recuperating from your stroke. So ideally we would all like to have every patient walk in and walk out as quickly as that particular patient did. Unfortunately,
That's
we
not always
don't get
possible.
to that point yet.
Yeah.
The second thing that I want to remind everybody is that just like with cardiac disease, many moons ago, we used to have patients having heart disease, heart attacks, and then becoming cardiac cripples. And now with intervention and with treatment, we don't see them anymore. In fact, you hardly see patients with congestive cardiac failure as we did in the old days. And ideally, we're going to get to that point. If we can get to that point, then yes, ideally, we're going to be in the better footing. So that's important to make that message across. Get to hospital because we've got methods to treat, and the methods to treat will bring about a significant resolution, allowing you to get back to function.
Absolutely. And we just will continue with Dr. Yacob's question after this short break. Please do stay with us as we chat about strokes and understanding the effects of it just after this. Assalamu alaikum, very good evening. Welcome back. This is Health Matters. Understanding the effects of stroke is what we are chatting about with myself and Dr. Yacob. We have a panel of experts in studio with us. Special interest in acute emergency stroke care within her fraternity of heading emergency units, as well as neurologist Dr. Pradeep Raoji at Milford Hospital. Mill Park Hospital. I'll get it right eventually. Our last segment, our last few minutes, we've got 10 minutes to wrap up, and I know it's enough cannot be spoken about, understanding, and as you're stressing, the time to get that stroke patient to the hospital. And as we also heard, the callers that are coming in are quite concerned about their loved one and themselves as well. We highlighted hypertension, our lifestyle, the things that we need to change, the things that we must change. How can family help those potential sort of loved ones that are at risk of strokes and it maybe has happened and recovering as well?
I think the prevention, as Pradeep was saying, the lifestyle changes is up to the patient and the family. So, you'll often find families where there's obesity because of the incorrect way they're eating. You have a family history of high blood pressure and diabetes that would be common to all people, and you want to prevent it in the younger generations. So it's essentially a lifestyle change for the family. It's not just the patient that has to be, sort of drastically now don't eat this and
Isolated,
exercise
yeah.
and whatever. And if you do it as a family, it makes it that much easier for the patient themselves.
Absolutely.
South Africa has the fastest growing rate of childhood obesity anywhere in the world because of all the junk food and the computer
it was
games.
America.
And
South Africa's on the top of the
catching up.
list,
We're
eh?
catching up very quickly.
Okay.
So, it's a worrying thing. So that's why I'm saying it's a lifestyle change that happens within the family. And that's for the prevention. Once they've had the stroke and the patient goes home and hasn't had treatment or can't be treated, it essentially changes that whole family's lifestyle because, the patient may be bedridden, they may be unable to feed themselves, they may be unable to talk or bath or dress themselves. So it literally becomes a 24/7
The family
responsibility for the family to look after that person.
The effects of the stroke, as Dr. Yacoob has mentioned earlier on, posing that questions at what's happening is the treatment, and like you said, it's a family of physicians that comes together to help this patient. So can it really be reversed?
Well, with treatment, yes, but also the research has shown that if the person gets treated acutely in an acute stroke unit, where all these facilities are available, the outcomes of those patients are a lot better than if they had no treatment. So even if they are not a candidate for the medication, for the drug that could dissolve the clot, just having them in a stroke unit or in a hospital where they would have access to that multidisciplinary team would improve their outcomes.
Okay. Dr. Yacoob?
Stents have radicalized the treatment of cardiac disease and ischemic heart disease and the strokes, the heart attacks that people get. What has been your experience now, and which way is it heading with strokes?
So in terms of the brain as a source or place to put in stents, that really isn't an area that we've actually been actively involved in. And the reason for that is that the blood vessels in the brain, if we rupture them, there's major consequences to that. The patient's going to demise. So the first rule would be immediately would be neglected in that we're doing harm. So we should do no harm. So stenting in the brain is not an area that we actually would want people to do unless it's appropriate and it's done in a really expert setting. The other area that they've tried stenting is in the carotid artery, where the artery has been narrowed. And even there's a subgroup of patients that we would want to stent, and only those patients would be stented. So it would be a patient who's elderly, who's unable to tolerate an anesthetic, who is at greater risk of having surgery than they're having the stent. And so that's a person you'd want a stent put into. So that's the one aspect. But I think the most important thing that I need to discuss is a stent in the setting of a clot of the brain, is that the stent is actually used to retrieve the clot. So it just so happens that when mechanical thrombectomy became a big issue, we basically looked at the data from medical treatment versus mechanical treatment. And the very early thrombectomy devices were really rubbish. And all they did was propagate the clot further along and did nothing for the patient, or the outcomes were not as great. The newer ones are much better in that they snare the clot and then they pull the clot out. And that's a stent device, and that's one of the things that we have available in our city and our country. And where there are facilities, we're hoping to get those patients across to those facilities to be able to reverse the stroke. And there's data now that says that up to 16 hours we might be able to remove that clot in the appropriate setting. So the appropriate patient with the appropriate investigations confirming that there's a possibility of removing the clot. And in those patients, there was a trial earlier this year that clearly shows that even in that group, in fact, this trial was stopped early because there was a benefit even at that late hour.
So that's a big benefit, and obviously we hope, obviously it's not going to be easily accessible to everybody.
Not accessible
but
to
the way
everyone.
it is, it's a big boon for treatment of stroke. at that early stage.
And understanding, what you're doing to yourself for the stroke to happen. We've heard the obesity, we've heard hypertension, some, stress possibly. Is that possible? Being overworked and stressed, does it cause one to have strokes? I mean, this 32-year-old I know does not have hypertension or any sort of illnesses, but she is, as I know her, very overwhelmed at times.
Yeah, I don't know that stress on its own causes any particular pathology.
Okay.
But it predisposes you to high blood pressure and things like that, which would aggravate the risk factors.
And stress is so difficult to measure. I mean,
Yeah.
it's a soft thing, it's an intangible thing. So, whenever people have some kind of emergency cardiac or vascular event, people say, please reduce your stress. It's like the common thing to say, but who can measure stress and what it is? And it's different for different
And
people.
also what's stressful for you may not be stressful for me. So
Yeah.
it's a totally subjective thing.
But it probably comes back to lifestyle.
Yeah.
But having said that, if
Yeah.
you look at most patients who have heart attacks and most patients that have strokes,
So, yeah.
there's usually a serious turn of events, either in the social or financial or other platform,
Yeah.
that produces that intense stress, which is not something that they're used to, that suddenly brings about the event. So clearly,
There's some
you
link.
may be
Factor.
sitting with all the risk factors, and then suddenly the stress comes along because you're sitting there merrily on your couch, nothing's happening. And then something happens drastically in your life, and that somehow does something physiologically to your blood vessels, which then and that's definitely there. So, no doubt about stress even though we can't measure it, it definitely
Okay.
does predisposes.
We've got a minute or so to wrap up, guys. So, Dr. Isak, any last words from our panel
I
here?
think perhaps the panel can just give us two very good take-home messages.
I think for me, it's prevention and being aware of the symptoms, particularly for people around the patient, and getting to a hospital as quickly as you can.
ASAP.
Yeah.
ASAP.
Fast, remember? Fast. If it starts drifting, if there's a facial droop, speech difficulty, let's get them to hospital. So
Sudden onset.
that's my only message is
Fast.
Fast must be remembered, it must be spread. The word must be spread.
And that Disprin.
And
Keep it in your bag.
And the Disprin, yes.
Dr.
All right,
Isak?
thank you very much. I think it was a very good show. We didn't really get a chance to get into the rehabilitation and what goes into it.
Yeah.
Perhaps we'll invite you again for that because I think
Always
that's a
need
key
to follow up,
component
yeah.
to the thing. And to the viewers, thank you for the questions. They were very
Participating.
good questions that came in today.
Absolutely. So, Jazakallah, thank you so much to our panel here today as well. Dr. Yaqub, till we meet again on this edition of Health Matters, from myself, Hawa Solomon, and from Dr. Yaqub.
Assalamu alaikum.
Assalamu alaikum wa rahmatullahi wa barakatuh.